Hello, my name is Alex Broom. I am Professor of Sociology and Director of the Sydney Centre for Healthy Societies at the University of Sydney. I'm delighted to join you all virtually to talk to you about the Australian experience from a sociological perspective of working and caring in the context of the pandemic. Now, the pandemic in the Australian context has gone through various critical stages, the start being virtually an absence of the virus, but a lot of fear and worries about what was going to happen, to now a scene of quite high rates of infections, but also better understanding of pandemic infection prevention and control. And we embarked on a qualitative sociological study of what it was like to be working and practicing in the midst of a very, very quickly evolving pandemic scenario in Australian hospitals. And this is part of this work I want to talk to you about today. And from a sociological perspective, the COVID-19 pandemic, the threat, offered unprecedented risk and uncertainty for the population more broadly, but health professionals in particular. So we're really going to focus on, in this presentation, thinking about that more sociologically in terms of issues of velocity and proximity, and how we might better understand healthcare professionals' experiences and hopefully develop protective approaches for the future in terms of how health professionals experience and manage pandemic scenarios. This work was a collaboration and involved a range of different researchers, including another member of the Sydney Centre for Healthy Societies, Dr. Leah Williams-Vesey. And her and I conducted qualitative interviews, mostly over Zoom, I have to say, given the pandemic scenario, which had its own challenges, in two different states in Australia, in New South Wales and Queensland hospitals. And these interviews were largely with doctors, nurses, allied health professionals, paramedics, educators, clinical managers, social workers, and cleaners, the whole spectrum of healthcare workers in a lot of different specialties as well. And the idea underpinning this was, what is the everyday experience of practicing within a pandemic, within a very, very quickly evolving landscape, and what might we learn both for the present and for the future from their experiences. What emerged was a picture of a complex interplay between issues of proximity, velocity, risk, and care, or what we might call a kind of ecology or ecologies of pandemic infection control. So I'm going to just give you a glimpse of the health professionals' experiences, reading out some of the excerpts from the interviews, which illuminate some of these kind of core challenges of the pandemic scene and the pandemic scenario. Very much centered around pace, the kind of paradox of distance versus closeness and what risks that offers, the issue of incredibly fast change in institutional practices, and how that feeds through to what care is able to be offered, who is able to offer it, and so forth within health services. So let me give you some insights into the qualitative interviews. And essentially, what this manifests as, or we argue in terms of this qualitative data set, is a kind of a sense of viral velocities in infection prevention and control. a kind of set of paradoxes around attempts institutionally to slow the spread, but also an acceleration in knowledge because of the levels of uncertainty. The sort of slowing down of decisions at the same time as having to actually speed up institutional change. So we've kind of got this paradox of delay as safety versus delay as risk, and indeed delay as care, caring for the professional, whilst not necessarily being able to care for the patient themselves. So this was a kind of a very interesting excerpt which captured a number of these dynamics around proximity. And this is one of our participants who said, and it was a nurse, there's nothing more demoralizing than watching two doctors argue outside the double doors who was going to come in when you've been the one in there for hours. Now, what's really interesting about this is essentially, from a sociological perspective, that the issue of risk and proximity was not linear, but rather situated in who you were within the health system. So whilst the traditional kind of power and authority of medicine was able to enact some degree of distancing and proximity or control proximity for nurses and other allied health professionals, cleaners, and various other workers within the hospital, there were no such opportunities to manage proximity, nor did they necessarily want them because they wanted to care for their patients. But it speaks to this issue of proximity as non-linear amongst health professionals and how various issues of status and authority shape who is and isn't able to manage issues of proximity. And we see some other quotes here from the data. The doctors ordered videos, phones to go into the negative pressure room so they could remain outside the room and converse with the patient via video from there. So that basically left the only person having contact with the patient as the nurse. So what you see there is a kind of a collective but non-linear distancing from care. The nurses were taking the meal trays in and the catering staff were staying outside. The only thing the nurses weren't doing is emptying the rubbish tins. Another person said, so we kind of felt like a bit like emotional cannon fodder. We felt a bit like cannon fodder. It was almost the feeling like, well, you're disposable, you're not as important. So what this speaks to is the intersection of kind of affective scenes within the health service, but also the issue of proximity and who can manage that, and how infection prevention and control is mediated by these dynamics. This also related to the issue of leadership within the hospital. Leadership was often perceived as being distant from the scene, despite the fact, and we'll see this in a later quote, that management of the health service was seen to be ramped up, we might say, within the pandemic. So there was more of an interest from a leadership perspective in what was happening. But at the same time, there was more distance between, physical often, between the kind of front line of care and the leadership of health services. So we never saw the chief executive. He didn't come down. Whether he stayed away, he may just not have come down to the clerical staff. They put out broadcasts and all of the rest of it to say, yep, you're doing a good job, but there's nothing like someone coming down telling you face to face. So proximity is not just an issue, obviously, between patients and health professionals, but also an issue between professionals and an issue of governance and leadership within a pandemic. The simple but vital matter of connecting with staff face to face, showing that there's a kind of a shared risk taking, was perceived as crucial within the interviews. You can see here in another quote from an infectious diseases doctor that there was another paradox around centralisation and autonomy. I found on a state level at least that the organisation came in very early from a higher level, and I mean the chief executive officer. It's been good and bad. It's taken away a lot of autonomy, and maybe this is part of the reason why I'm talking about redundancy of infectious diseases, because our autonomy has been taken away the chief health officer has taken on a horrendous amount of work and a lot of risk associated with what's going on with COVID. So this is another really interesting dynamic, which is the pandemic was so unprecedented. It created high levels of interest centrally from usually rather distant executive, but then resulted in removing some degree of autonomy and control from the front line, from those who knew best what needed to be done. So within the health services, within the hospital sector, there was often some degree of paralysis because the power shifted centrally because of the acuteness of the pandemic, which gave limited flexibility on the front line to actually make changes as needed and as evidence emerged. So returning to this issue of velocity and speed, which emerged as a kind of a crucial narrative within the interviews, was a sort of paradox of this incredibly swift moving pandemic, but the contrast between that and the positionality of we need to go slow in order to get this right. I.e., and captured in one of the participant interviews, there is no emergency in a pandemic. So, and I'll read out a nurse's quote, which was very interesting. We were always encouraged to never rush into a room. There's a sign out there saying there's no emergency in a pandemic. We had to make sure that we were safe before we went in, which really went against the grain. I had trouble making sure I did it slowly, and the patients then they're going, help, and you just can't go, I'm coming. You have to make yourself safe first. So that was really hard to do. You're having to put yourself first, safety of yourself first. That was something that was very difficult. I felt fearful for the patient because it took too long. The process was pretty long. So again, we see a kind of a paradox because on the one hand, the only safe option for the health professional was to actually go slow. And the level of uncertainty and risk was extraordinary. And therefore, this kind of paradox emerges where obviously there's sort of acute health needs and patients potentially with very difficult and unruly kind of bodies and situations. However, on the other hand, the risk and the uncertainty slows down what would normally be an acute situation where care was needed to be provided very fast. Another quote on the velocity of care from a pediatrician is, as soon as you think they may have COVID, the door gets closed and there's no ability to really monitor them closely. I mean, you could argue, yes, just stay in your PPE and stay in the room, but we don't have resources for that. So it's a barrier to go in and eyeball somebody in a very timely manner. Because as soon as you have to put your stuff on, you're kind of going, well, I'll wait. I'll do it at the end of the ward round because it's not going to slow me down or whatever. And that's not good for our patients. So the scene is very much one of, once a COVID patient, the deal changes. Things move very quickly to a sort of a point of paralysis where there's no ability to actually get close, returning to the issue of proximity, but also an issue of speed. What happens when the COVID or the category of COVID gets implemented within the health service? Finally, a paramedic said, for years it's drilled into you that time on the chest is what saves lives. But now there is no CPR until the patient has a face covering. You stop CPR when inserting an advanced airway, things that go completely against all of those really ingrained processes. But at the same time, I understand that the organisation is looking out for us. For years, we've said ambulance doesn't necessarily look out for its staff, but by introducing these changes, that's not for the patient's well-being, it's actually for our well-being, and trying to comprehend that it's a challenge. So that's a really interesting mix of different interpretations. The previous kind of world or life world of the paramedic, which was largely about prioritizing the patient over the professional. And with the move or with the rise of the pandemic kind of milieu, it then becomes an issue of protecting the paramedic and the organization and the health professional. So it's kind of shifting the priorities subtly sometimes and explicitly at other times from the person to the organisation, largely to do with the viral threat and how it changes priorities. So I've given some very brief reflections on quite a large data set, and I'm very happy to send through papers which analyse the data in more detail. But really there's sort of three key, I guess, issues for the future of hospital-based healthcare to think about as a result of these interviews. The first one is around proximity and how that might play out in the future. So will this kind of hypervigilance around proximity continue? What will the implications be? How might we provide resources and training and so forth to actually find our way out of some of those more problematic issues around proximity? Hopefully, we can work towards thinking about velocity and a sort of acceleration of practice and evidence and uptake therein, and think about how that might be done more effectively for future pandemic scenarios. There was a lot of circulation of hearsay, rumour, and internationally around what was happening, what was best practice, and systems were not necessarily organised. The velocity outpaced the capacity for organisation. So hopefully we can proactively think about how to manage that in future contexts more effectively. The third point is the issue of acceleration of information sharing and learning. And I think one thing we've certainly seen is the importance of continuing the importance of craft groups and specialist groups, and not necessarily having centralized control of everything. That ultimately specialisms and groups with special interests in healthcare systems are actually very effective at identifying what they need, and also pushing back on some of the more centralized guidelines that don't necessarily make sense. So I think layers of information sharing and expertise, both nationally and internationally, will be very important in the context of future pandemic scenarios. So I hope this has given some reflection on how we might think about, sociologically speaking, the dynamics of proximity and velocity in the pandemic kind of infection prevention and control environment. And I'm happy to share papers if people are interested in hearing more. Thank you.